official. Okay, is everyone able to see and hear okay?
Yeah.
Okay, so this week I'm presenting a case study called Ying's illness. And essentially, we're going to talk about ethics related to the care of adult and critical care nursing. And so we'll just jump into that now. Let me go to the next one. There we go. Okay, so on this slide, I'm going to give you guys just a little background about what the case study involved. And that way, we'll be able to see how ethics is related to the details of the case study specifically. So it starts out with a story about family members, and I'll give you the breakdown of who the characters are. So the main patient, her name is Ying, and then Min is Ying's sister-in-law, and then Wei is Ying's brother. So these three people are the central characters of the story, but Ying, like I said, is the main patient. So the story begins out, or the case study begins with Ying experiencing a fever and pain while swallowing. And the family members become really anxious because they're really nervous about trusting Western medicine. They actually have a traditional Chinese background, so they prefer to try things like herbal medicine treatments and prefer to kind of stick with their culture in terms of dealing with illness. So the sister-in-law and the brother, they pursue the Chinese traditional treatments, and unfortunately, they're ineffective. And so what happens is Ying has to go to the ER. So now we're transitioning into a hospital scene, and Ying is now admitted as the patient, and she has her sister-in-law and brother next to her. And she gets diagnostic testing done and finds out that she has streptococcal pharyngitis, aka strep throat. And when she's talking to the doctor, he is really concerned that she might have something related to a heart issue, especially because of her traditional Chinese culture. He said it could be more common with her for this gene. So the doctor comes in, he's explaining to the family that he needs to order an echocardiogram to see if she has anything wrong with her heart. And also he would like to do blood work to assess for any genetic conditions related to rheumatic disease. So at this point, the family is already really nervous about trusting Western medicine instead of Chinese traditional medicine. And so they start asking a lot of questions, and the doctor is trying to explain, but the problem is a lot of this information is outside of his specialty. So he essentially gets flustered and just kind of shoves the informed consent to the family members, and they sign it. And in the context of this, there is a language barrier because the family has a Chinese background. And so the doctor is at a standstill with explaining it. So he kind of rushes through the informed consent. So I put stars next to the next ones because these are points in the case that really highlight some of the ethical issues. So as the family is becoming worried and they're not being properly informed, the doctor does not come back to try to explain, and he does not also get a medical interpreter to help. And so he does come back to the room again with information from about the genetic mutation. And like I said, there's no interpreter in the room. So he quickly explains it, hands him the folder, and bolts out of the room. So we kind of have two instances where this poor doctor is getting flustered. I'm not sure if it's over the language barrier outside of the specialty stuff, but again, he rushes information off and does not explain it properly. So in the end, we see that Ying was discharged before anyone could explain any type of genetic testing that happened for her. She didn't get full explanations of her treatment plan, follow-up instructions, or preventative treatment options. And the biggest issue with this is that now Ying is leaving the hospital without truly understanding her condition, and now she's at a risk for a heart disease, such as rheumatic disease, because of that genetic mutation. So another issue with her discharge was that the follow-up plans and treatment recommendations were not documented in her chart. And so there was documentation that wasn't completed, and now Ying is at risk of this heart condition. So that is a little bit of a summary about what was going on. Okay, so then when we're looking at the case, it's important to identify the areas that are specific ethic issues, and it's important to also think about what specific ethic principles are being violated. So in this first example, Dr. Smith was unsure if he was explaining the questions related to rheumatic disease correctly. He has the family sign the consent form without explaining rheumatic disease, its implications, and genetic testing. And in this case, several ethical principles were unfortunately violated, including autonomy, non-maleficence, justice, and fairness. Now, another point in the case study where there was a medical or ethical issue was when the case did not include a medical interpreter in the room when Dr. Smith was giving the genetic testing results. So again, autonomy and the same principles as mentioned before were again violated. Another point was when Ying was discharged without an explanation of her genetic testing, the treatment plan, or follow-up instructions, and she was not educated about preventative treatment options or a follow-up care plan. And so again, her autonomy and non-maleficence was involved in this case as well. So we'll kind of dive into some of those later, but it's important to just kind of keep those on your radar. Okay, so in the case, we're going to talk about the medical indications of what happened with Ying and her family. And so the ethical principles here at the top of the slide, and these relate directly to medical indications. So we found out in the story that Ying's primary problem was streptococcal pharyngitis, aka strep throat again. And essentially, this is an infection of the oropharynx, and it happens from streptococcus. And so she did have some of the symptoms that were directly related to this before she was even diagnosed. She did have a sore throat, she had a fever, and she also had painful swallowing. Now, the treatment for this is usually antibiotics, and it can be penicillin or amoxicillin, which are the antibiotics of choice. And also, as the nurse, it's important to think about the side effects of the antibiotics to make sure we're educating her family properly, of course, with a medical interpreter in the room. Now, Ying did leave the hospital not truly understanding her condition, so she is at risk for more than just rheumatic heart disease. She can also get a peritonsillar abscess, retropharyngeal abscess, or mastoiditis. So in this case, we are expected as healthcare professionals to make sure we are educating our patients in their primary language with the assistance of a medical interpreter to make sure we are doing beneficence, which is we need to do good for our patients, right? And to do no harm, which is the other side of the coin, which is non-maleficence. So this is a little bit about how treatment explanation helps us uphold our ethical principles as healthcare providers. So now we're going to move on to talking about patient preferences. And the main one here is autonomy, which is probably one of the most obvious ones that was violated in this case. So the story starts out with Ying's family being a little bit distrustful of Western medicine and trusting more in traditional Chinese methods. And so when they get to the hospital, remember, Dr. Smith was kind of educating outside of his specialty, so he wasn't properly educating about it and kind of shoves the informed consent to them. So in this, the overarching idea of this slide is that Ying's family was not provided a medical interpreter at the appropriate times in her treatment, so she could never truly weigh the benefits and risks and ask questions about what was going on with her treatment or what she was being diagnosed with. In this scenario, the patient showed that she was mentally capable. She was able to understand all the language from her family members in her primary language of Chinese. And so that shows that she could have really responded well to using a medical interpreter. Like I said, she couldn't express any preferences just because of the language barrier. And because Min and Wei, which are her family members, they were just feeling so afraid and nervous and wanting Ying to get help. They were like, we'll just trust the doctor and sign it because, you know, they were feeling some sense of confusion, but they're most concerned about Ying getting medical help. So in this case, again, just to summarize, autonomy was not really an option for Ying, and unfortunately, just because of the language barrier. All right, so let's move on and talk about quality of life. So the ethical principles are at the top of this slide, and so Ying was discharged without an explanation of her genetic testing or any information about her follow-up instructions. And if she had treatment success where she was properly educated and knew her options, she'd be able to return to daily life without experiencing uncomfortable symptoms. Her emotional impact would be that she may experience decreased fear and anxiety, because understanding your disease and building that rapport with healthcare members can really help her grow trust in the Western medical system. A physical impact is that she could learn more ideas about lifestyles of wellness and how to attend to her preventative care if she were to come upon rheumatic disease. And also, one of the most important things is to prevent complications. So we talked a little bit about this earlier, but if she was left untreated, which she was, unfortunately, she was at risk of complications. And with rheumatic heart disease, one of the biggest things is that she might need a heart valve replacement. So that also has financial implications as well, because, you know, this is kind of multiplying into a larger medical issue. All right, so let's talk a little bit about context of the story. It kind of shapes the ethical principles and the situation that Ying and her family were enduring. So Min and Wei are helping Ying navigate treatment in the hospital setting, and they were wanting to help with clinical decisions, and they ended up signing the consent form the doctor gave them. And the most important thing is that HIPAA says that it must be signed, the informed consent must be signed by the subject or their legally authorized representatives. Now, Ying does live with Min and Wei in her home environment, but they are not her legal representatives. And so with a medical interpreter, Ying would have been able to sign the form after she was properly educated. And also HIPAA states that you must be authorized under applicable law to consent on the behalf of the prospective subject. So again, they were not legal guardians for her or legal representatives. So in this case, it would have been best to get the proper resources, medical interpreters, so that Ying could sign the paper. So another thing we want to talk about is the perspective on medicine. Min and Wei were really apprehensive over Western medicine and really prefer to use Chinese traditional methods. It wasn't until their back was against the wall that they decided they had to go to the ER just to make sure Ying was stable. So one of the biggest context issues is the language barrier. And again, that's kind of hitting on needing that medical interpreter and the healthcare team being able to understand the needs of the patient. And lastly, I want to talk a little bit about healthcare team interactions. Dr. Smith is explaining information from outside of his medical specialty, and he's unsure that he's offering the correct information. It's really dangerous for the patient, and they're not getting the correct information. So it could be hard for her to make informed decisions about how she wants to move forward in her care. Okay, so let's talk about the difference in perspectives, because there are two sides to every coin. So the original perspective would be the healthcare team is at fault because they're not requesting the medical interpreter, they're not fully explaining informed consent, and they're also not completing documentation in Ying's chart. On the other side, some could say the family may have not fully understood rheumatic disease or its implications, even with a medical interpreter. And they may still have signed the medical or the informed consent, even with misunderstanding. So in that case, someone could have interpreted and maybe they could have been embarrassed or just overwhelmed and just said, yes, I understand, and signed it. So there are two perspectives here. All right, now it's important to kind of tie it all together and see how this case directly relates to the American Nurses Association provision. So the provision that stood out most to me was provision 1, and I'll read it here. And it's provision 1. So it goes, the nurse practices with compassion and respect for the inherent dignity, worth, and unique attributes of every person. So each provision is broken down into subsections. And the first one, which is 1.2 I want to talk about, is mostly hitting on relationships with patients. And it talks about how factors such as culture, religion, spiritual beliefs, lifestyle, and social support are to be considered when planning care. So this kind of comes back to the idea of providing individualized care. So despite the language barrier, Dr. Smith did not request a medical interpreter when explaining the genetic results. And so our role as the nurse in this situation would be to provide culturally sensitive care, prioritizing the needs of the patient, and also requesting a medical interpreter on the behalf to help facilitate that communication and make sure everyone's informed. This also gives the patient a chance to ask questions, express concerns, and it's also really important for the doctor and the nurse to know that they had reservations about Western medicine. That way we can make sure we're using therapeutic communication to kind of bridge some of those gaps. Another subsection of this provision is the right to self-determination. And this mostly talks about patients having the moral and legal right to determine what is done through their own person. So this kind of hits back on that autonomy idea where if you're informed about your decisions, you're able to make better ones. And so they should be given complete, accurate, and understandable information in a manner that facilitates an informed decision. And in this scenario, the consent is given to the family and they sign it without truly understanding. And so our role as a nurse would be to advocate for the family and possibly ask the doctor to return back to the room after assessing the family and maybe them expressing that they had some confusion. Okay, so there's another step beyond the case, and this one involves applying the principles that we learned from Ying and her family to other content related questions. So the first scenario talks about a couple who doesn't speak English and they're wanting to family plan and they are concerned that their wife's sister has cystic fibrosis. So it's important to note here, we're talking about the informed consent again. And for one patient, the informed consent is in English and the wife's able to read that A-okay. The husband, on the other hand, has limited English proficiency. And so for him, he is not able to understand the form properly. So again, we have our two sides to every coin again. So the ethical approach would be to request a medical interpreter, right? Just as we kind of talked about with Ying's case. And we want that to be in the primary language. And so it's important that even the medical interpreter is adhering to ethical principles, making sure they're proficient in whatever language is selected. And they also need to be able to use specialized vocabulary as necessary. On the other side of that, an unethical approach would be able to say, hey, just sign the form. Your wife can explain it to you later. Because in that case, we are not doing our full duty of making sure the patient is informed and we're passing off a responsibility that we shouldn't be doing to the wife. And so again, we want to make sure we're providing culturally sensitive care and making sure that informed consent is conducted in a language the patient understands. So informed consent is very important. So there's another scenario as a follow-up to this one. And this one's about a patient who's undergoing gastric bypass surgery. His main concern is that he doesn't want anyone else to know the type of surgery he's having. And he expresses this to the nurse. So again, there's two sides to this situation. The first side is the ethical approach. And this would be where the nurse can inform the patient that she does have rights under the HIPAA Act, where her information is protected and healthcare members will not be sharing her information without her permission. And so here we have the privacy rule. It says it does not require a healthcare provider or the health plan to share information with family or friends unless they are legal personal representatives. So this is something that's really important for the nurse to inform her about because this is a right that the patient has. On the other side of this case, the unethical approach would be to still disclose information about the patient's surgery and essentially ignore the fact that the patient must authorize for any information to be shared. So this is really important, again, just educating patients about their rights and knowing that they really are protected under HIPAA. All right, so I've been pretty chatty and now we're getting to a point where I will kind of want to hear some of you guys' thoughts about Ying's case or even about some of the last cases we talked about, and I'll kind of go back to those in a bit. So I'll go ahead and read through the first question and you guys feel free to tell me your thoughts. So in the first question, it talks about communication. So how is communication between the provider and the family members? What do you guys think?
I mean, I would say that the communication was not good because I think that they didn't really take the time initially to understand, like, you know, why they were using like Chinese medicine versus Western medicine, and to like kind of accommodate those things. Like you should always be aware of like, you know, what they would prefer. And then also like they weren't talking about, they didn't fully discuss like the genetic testing results or anything, or even like use an interpreter or get like a specialist to go over it. So there was like a lot of things lacking.
Anyone else have any thoughts about maybe what they could have done better to help with the communication?
Yeah, I agree with Delaney. Like it was lacking in pretty much every area. And it's kind of interesting though, like usually other, you know, like staff members can pick up on that. So for example, if there was a nurse in there with one of the doctors, she might have picked up on the fact that like maybe he's either rushing through or he's not covering everything, and or the patient is clearly not understanding, or maybe their family is confused. And a lot of times, like I've seen this happen before, like the nurse might intervene and just say like she might even stop the discussion, just say, do you want me to go get like an interpreter? Or, ask the family if they want an interpreter, and then just go run and get like the iPad. So that way the doctor can just call it up really quick and then they can get an interpreter on the line. And usually, even though sometimes that can be like disruptive, it obviously works out way better for the patient and the family because they are getting the information that they need, and they don't have to go back over, like, say, for example, if the family did have questions, they wouldn't have to go back over repeating stuff. If it was communicated like effectively the first time. So I just was like, I kind of was wondering the whole time about, some of the other members in the healthcare team that might have been able to step up or see that and kind of intervene a little bit. But yeah, that's definitely a big issue, especially if the provider's kind of not meeting their responsibility to make sure the patient understands their condition and situation, which is the whole reason why that they're, in the hospital in the first place. So
I think that's a really good point because, sometimes there's occupational therapies in the room or physical therapy. So they might even notice maybe before us sometimes if there's a language barrier. Sorry, yes, I unmute. Go ahead.
And it's kind of unfortunate too about how poor the communication is, because even though it seemed that the doctor was rushing through the process of this care, that it ultimately will add in more time in this patient's care with the whole team, not just this doctor, because that's going to be extra care when she ultimately does need to come back, because the likelihood of a complication or questions is pretty likely.
That's a really good point.
I was gonna say, going off of what Kim was talking about, is like, I know too, like as nurses, like we should always kind of clarify to like make sure that the patient is like, understanding like what's being done, as well as like just making sure that they're satisfied with like the care that they're being given. So I do think like it would be important, and I was questioning as well, like where was other people on the team to like come in to clarify those things, because if you were to ask to be like, okay, you got these results back, how do you feel about that? And they were to say like, well, I don't really know anything about it, like we could have, as a nurse, you could go in and be like to the doctor, or like get a referral for another like member of the healthcare team to come talk to them.
Mm-hmm. Yeah, that's a really good point.
Yeah, I was just gonna add on to, like, I always thought that whenever like I saw that like happen in the ER or whatnot, it was kind of pretty cool because it just seemed like the nurse kind of stepping out and doing that, or even like what Lindsay was saying, like even if it was someone not a nurse, even if it's like a nursing assistant or physical therapist or someone, that's like an indirect or passive way of advocating for the patient, because it's showing that you're like astute and aware to their needs without verbally having to, address them specifically. If you just like say, hey, I'm gonna go get the interpreter, or, do you guys have questions? Even if the patient's too worried or scared to step up or say something, that you're kind of taking control of that and not, putting it on them completely. It's more so that you're just picking up on maybe their nonverbal expressions or feelings.
That's a really good point you made too about the nonverbal effect, because sometimes in the body language, you can see someone saying like, yeah, I feel great about that. But then in their body, it's telling you completely opposite. And so I think that's something that as nurses, we'll be able to see a lot because we're at the bedside compared to the doctor all day. So we'll be able to have eyes on that for them. Okay. So for the next question, how would you discuss the integration of Western medicine into the family while still honoring the family's traditional approach to medicine? And their traditional approach to medicine just kind of talks about the herbal strategies they were using for Chinese medicine. So how would you kind of almost build trust in the Western medicine system while still respecting their personal culture?
I think first you just learn about what they do. And then from there, because you can't really start pushing Western medicine without honoring what they do normally. So I think that's what I would start with, is just like take the time to learn about what their routine would be if they were to do it their family's traditional way.
I agree with what Lindsay was saying. It's pretty much along the lines of what I was going to say. And then I was also going to say, like, going like past their routine and whatnot, you know, some of the like Western medicine stuff kind of encompasses like acupuncture and things like that too. So it's not so much having to take supplements or, you know, actually ingesting herbal remedies. It could be complementary. So you could still, you know, take the actual pharmaceutical medication or treatment and then pair it with acupuncture or something that's not actually ingesting, like, for example, I know garlic is really contraindicated in a lot of different types of like pharmaceutical medications that we have as well. So
I also think research should get interactions between what their home remedies are and anything that they would be given in a hospital setting, just to make sure that I guess no interactions happen.
I was gonna say, to add to that, it's like, I think it would be important to have a conversation with the patient and their family about like why they're so against Western medicine to begin with, because it would be a great like point of teaching to kind of discuss like what Western medicine is about and to try and get them on board with the treatment plan, rather than just like your family, your mom or the patient is like super critical right now, so we need to give them this medicine so it can be life-saving. Like, I don't really think that for people who are so against Western medicine, they're going to accept that as like a totally like great reason in the beginning. And I know that like towards the end of it, they were like a lot more on board with it, but I think that they still don't totally know what Western medicine is all about.
Yeah, this whole experience almost opened a whole other world they didn't even know existed, literally, you know. And after they saw Ying was stable, I think seeing her safe and being able to connect those dots, saying, okay, Western medicine is being used, but also my family member is stable and she's able to return to life. Maybe this is not so bad, because maybe they're seeing, you know, Chinese traditional medicine and Western medicine, there are different approaches, but they're trying to go toward the same goal, which is helping the person live a healthier life. So I think that was interesting that her family member had almost a change of heart after that experience. And who knows if it would have been different if he was hearing it from back home, maybe about her care versus seeing it for himself. So I think that is important to having the family at the bedside and providing family-centered care, as we've talked about in some of our other classes, making sure we're including the family, but also respecting those legal rights that the patient has as far as informed consent and signing documents. But it's important to assess how the family is feeling, because, you know, oftentimes they're the caretaker. So their emotional state can be just as important as the patient's state, especially if they have so much of the physical labor as their responsibility. And there's a lot of implications that stress into their life as far as like finances. They could be helping finance Ying's medical bills. She's living with them, so maybe they're helping support her in that way, just giving her a place to stay. So I think, like you said, Delaney, it's really important to just ask questions and get clarification. I'll move to the next one. Was the communication surrounding genetic testing handled properly? Why or why not?
Well, I think that the communication was clearly lacking.
Yeah,
and I think that I think it's really hard to, because like at the end of it, everything wasn't documented. So even after she got discharged, just because the hospital is really busy, like no one's totally gonna know. Like she could have this like fatal heart issue that happens and she could die, and no one's gonna know why, because there's no documentation of it, and like the family doesn't know anything behind it, so they didn't know a treatment plan. They don't even know anything like about how it happened or what could happen, really. So I think that there's a lot of issues with not having proper communication in that.
Definitely. One of the things I thought about too with this case is because, you know, healthcare is in a place right now where it's really technology heavy. So, you know, how we go to the doctor, we might get labs done, they upload them in our Atrium or Novant portal. And it's really a lot of responsibilities on the patient to look at those, you know, because sometimes they're loading it and moving on to the next patient, not out of like ill intent. It's just they're busy and have a heavy patient load. So sometimes if you have an abnormal test result, you might not know unless you do the follow-up yourself and look in your own chart. And I think that would be challenging for, older patients or even patients that do have a language barrier, because I'm not sure if their chart in their portal would be in English. And so maybe that would be really overwhelming to try and look when they go home. Or it could go back home and be like, yeah, Western medicine was great for this one time, but we want to transition back to traditional measures as far as trying herbal treatments from here on out. So I think like having a follow-up is something that's really important with patients, whether that's a front desk person that calls and says, hey, like, how are you doing? I'm just following up with you. Do you have any questions you want me to relay to the doctor, the nursing team? I think that would be really helpful, because that would be less overwhelming for the patient and just help keep an aspect of accountability. And so that's what that kind of made me think about. Okay, let's move to the next one. Were any professional lines blurred or crossed? Why or why not?
I definitely think that maybe some lines were blurred in the aspect of, I think maybe, I just think looking at the entire situation, if someone goes to the hospital, I don't really think that like there would be no other staff, as we had kind of already talked about, like nurses, aides, like lab, people or anything. So I think maybe everyone had just assumed like the doctor was explaining everything, and maybe that's why they didn't care to like delve deeper into seeing like how much the patient knows, or like what further time needs to be spent like regarding the treatment plan or any issues that are coming up, or explaining, Western medicine or anything like that. Because I think like they didn't, from like she was taking like penicillin or something like that, and she had gotten a rash, and the like no one even explained to the family like, we're going to stop her antibiotic because she's having a reaction to that. Like, so I think the simplest explanations could have done a lot, and maybe people just assumed, like part of the healthcare team, people just assumed the doctors were already covering it all, so they didn't need to.
I think too, like a lot of the corners were cut, along with like the professional lines being blurred. I just wonder too, I mean, like outside of the hospital setting, usually if a family member or a friend or somebody that you know has left the hospital, you'll probably hear about it. They'll mention it in conversation about how they're doing, and then they will mention that they went to the hospital, and they'll be like, oh my gosh, what happened? And you talk about it. So I wonder too about kind of how this would just turn right back around, and get put back into the hospital setting, especially with her not understanding why stopping medication, starting them. So I think that that's just where a lot of the lines were crossed. Plus, there's not much of a debate on who's at fault at this point. We were kind of like back and forth about what to do with the last case study, but this one, it just
seems more clear.
There's a lot of people in the healthcare system, so I'm just a little surprised that of all the people, there wasn't somebody that had said something before. But like Delaney mentioned, that the hospitals are busy, there's a lot going on, and if the patient doesn't know to ask, sometimes the silence, people interpret that as they got it, which isn't always the case.
Have you guys ever had a moment where you're at work or you see something and you're like, you're having that internal battle, like, I want to say something, I'm comfortable, I should say something? Has that ever happened to you guys? Because I think as in nursing, we're kind of going to be the eyes and ears and feet and all the hands, everything for patients, especially in advocacy. So it's like this backbone that we have to have. And nursing is an art, so it's not going to look the same for everyone. But I think it's important to think ahead about some of those moments when you might have to talk to a provider with something that you're uncomfortable with. And I think that's a time to remember that people are on the same team, even if the levels of education are different or the roles are different. I think it's important to remember for everyone to kind of level out and have humility and say, okay, like, is this the best thing for the patient? And approach it as it's us versus the problem, and not a me versus you thing with the patient in the background. And And so I think it'll be interesting, especially with us as new nurses and graduating during a pandemic, what kind of things we'll encounter. And so I think this discussion will be applicable later too. So
I think the point too about that is like every patient's not really comfortable in a hospital setting anyways. And so they probably don't want to ask all the questions that come across because they don't want to hang out there for any longer.
yeah.
And if she's already confused and everyone's flustered and there's a lot going on, that the patient will probably just think that, well, this professional's talking to me.
Mhm.
And so the professional is setting me up for success, which
Mhm.
is another reason why nurses should advocate for their patients. But it just ended up sliding by.
Something else I've kind of like noticed too, like, and it might be applicable to the situation, I don't know. But like sometimes when patients get really anxious or they're getting a diagnosis that's not great or that seems very complicated, they, kind of shut down. They don't want to ask questions, or their brain is so overloaded with the thought process of the disease or like what's just being given to them that they don't even comprehend any kind of questions to really ask or process, even before leaving like the ER or the doctor's office or whatever. So like I think that kind of goes back to the other question too, where why like follow-up is such an important thing as well. Because I've been in situations too before as a patient where I hear something really quick about like what's going on. I leave the doctor and then the next morning I have a list of questions, or same with one of my parents. I might have a list of questions for the doctors for something that my parents went through. And there's been situations where they do follow up and call back and I'm able to ask the questions. But yeah, I think that's really important too, is to like remember the situation that the patient is in general, and anxiety, sometimes how people deal with it is just by internalizing and not processing or speaking up or asking questions.
I was gonna say like one thing to add in terms of like I felt like a line was blurred is like I always think too, especially like when we read patient notes and their charts like at the hospital, it always says like this was like transferred from like a voice recording or that kind of thing. Like there's so much like technology available now to like record your thoughts so you can get back to it and still document on it later. So I was also thinking that because I was like, well, this resident or the doctor could have easily made a voice note and been like, I didn't have the time because I got pulled into these other things. I need to make a note to either go talk to this patient later as well as document on this, because those things weren't done. And then I was also thinking like, it had said he moved on to the next rotation. So I was like, well, was this like in the point of view where the doctor was thinking about it later, like, oh, I didn't tell her anything. And now they're discharged and I'm on a new rotation. So it just doesn't matter. Like, I was like, you should probably go tell someone can make a phone call, like something could be done here so that proper management can still be done. But so I was thinking about those things as well.
Something interesting that like Delaney brought up was like the note taking, and I know we've all seen doctors who have scribes and whatnot. So maybe that's something, and I know that some doctors can hire or residents can hire them like on their own as their own accord. And then some hospitals provide them at like a discounted rate for them hourly or whatnot. So like if a doctor goes through several patient situations where they do that, where they're like either cutting corners or they're too busy for, actually explaining or notes or whatnot, sometimes like if they have enough self-awareness, maybe they can look into like things that can help them, like either voice recordings or scribes or whatnot that can follow them.
I think something too that's important to note is, so they have a situation where there's a language barrier with the family speaking Chinese, but there's also the second hoop is what's their best learning style, because they could sit there and explain maybe like all verbally without showing maybe a brochure, or they have channels that patients can go on their personal TVs and look up educational programs. And so it'd be interesting to see, how far even the medical interpreter would go, as the nurse is talking to like cater to their learning style, because that would be another barrier if just speaking like face to face is still not enough. Maybe they need to see a picture or see a diagram. or maybe like Kim was saying, they might need to have a moment where the interpreter and the nurse and the doctor leave the room so they can just talk as a family and process through things, maybe as like an emotional support system. And so I think there's so many angles to approach this to make sure the patient is comfortable. That is something else I thought about. And yeah, I was just thinking about it. I'll go to the next question. Were the appropriate steps taken for Ying's care?
I'd say probably not. They probably should have waited for an interpreter if they could have.
Mhm. One thing the nurse can do too is, well, we know different floors have different amounts of busyness, but if you see a doctor going to the room, trying around with them, I think is really huge, whether that's the beginning of your shift, which could be hard with med pass, getting a report. But if you're happen to be next to the room, because I would see some nurses say, oh, what did the doctor tell you? You know, so there's already a potential for a breakdown in communication if the patient didn't understand everything the doctor was trying to explain, or it was really, really fast because they have so many patients to round on. So I think that would be something that would be great for doctors too, to be like, hey, let's go find your nurse so we can both be in the room. Everyone's on the same page. Everyone can ask questions at the same time. I think that would be something that's important as we're practicing, if possible, and time allows, to round with the doctors. What do you guys think about her family and their reaction when the doctor came in flustered? What do you think would have helped them? I guess providing family-centered care to help ease them, because they were just as flustered as the doctor was on his end. What do you guys think could help the family members feel more calm?
I definitely think that someone should have been with the doctor. A lot of times, like we were saying before, usually there's someone else, whether it's a resident or another nurse, or even like, an assistant, a scribe, someone is usually with the doctor whenever they're really talking about any kind of diagnosis or treatment with a patient, or any kind of news pertaining to the patient, like especially with a family member, if someone like passes, or they're doing different things or different interventions. So I think that going forward, that would have helped the family a lot, just having a second person there.
Yeah.
That way that person could kind of like read the nonverbal communication and see maybe how jittery or on edge the doctor was, and then how the family either felt that way or was feeding off of that energy, and maybe how that person could have interjected again, like we were saying in the beginning, kind of.
I think too, like the relationship with the doctor and the patient is so important, even though we spend more time with the patient, kind of like how some new moms that are expecting, they want their certain doctor with them because they have a good relationship with that. I feel like that should be in play with any sort of care, no matter if it's a, labor and delivery situation or not. So this situation would be worth it for even like any nursing assistant, anyone in the background, to kind of see that this relationship isn't jiving, because it's obviously stressful for everybody in the situation. Maybe remove this person, bring in nurse practitioner or something, just the time being, maybe. And maybe the doctor takes a breather. He maybe finds another patient, sees that patient, comes back.
If you guys were in the family's shoes, what do you think would make you feel listened to? Like what actions by the doctor, whether that's eye contact, anything come to mind?
I was gonna say, like, I think it could have been beneficial if they tried to find, like, usually there's some people like within the system who have who are like holistic doctors, or like a holistic nurse practitioner, or even calling I know that they had given the list to or their phone number to like their herbalist or whatever. So like I think even calling someone to integrate like what they're typically used to try and feel more comfortable with what's being told, because since they don't typically go to like Western medicine hospitals or doctors or anything like that, they may not know that like something's totally off. Like I'm sure that they probably would have picked up on it with like intuition, but like they may not have known like that's not a normal thing. So I think like that could have been beneficial, or as well as like, I don't know, like you said, eye contact would be great, but I'm sure that he was just trying to get everything said so he could race off to the next thing.
I was gonna say, like, and I don't understand why. I've seen a handful of doctors do this in the ER, but it's always been, to me, like, even when I'm in the room, I feel a lot more calm when they do this. And they like take there's like a chair, like a wheelie chair that doesn't have a back or anything to it, that's kind of slid under either like the sink in the ER or like a desk that's out of the way, and like they go over to the chair and they like sit down and pull it over up next to where the patient's bed is, and they like talk almost eye level with the patient, but then they're also able to talk eye level to the family who's sitting on the other side of the bed. That always made me feel super calm, and only like a handful of doctors in the ER that I worked at did that, but I thought it was like, I don't know, it's like a different level to me of like professionalism. And then it made me feel like really whatever they were saying in terms of the actual treatment or diagnosis or like prognosis of the patient, it just seems so much better delivered to me, like a lot more calm and understanding and personal. So
Wow, Kim, I never thought about that because, so a little background, I had kidney stones the first week of school. I told Delaney actually, and the doctor did that. And I actually did feel really calm at 3 a.m. with kidney stones when he pulled the
it
chair.
makes a difference.
Yeah, there was like a lot of eye contact. And I think in our world, it's easy to be like Apple Watch, phone, charting, like a lot of things are going off at the same time. So you feel like everyone knows there's like the elephant in the room of busyness, but they're sitting down, so they might be inside like, I need to leave the room and find, like, check on another patient, but at least like it appears that they're really calm and don't have to like kind of rush out. So that's actually something, like a gift I didn't know I got to experience. Thank you, Kim. I didn't know that would make me more calm. For me, I think it's really helpful when doctors, I guess, now pull their chair over. That's something I didn't know about myself. And are making eye contact and just like asking more questions, I think, because sometimes it can feel like if they've kind of talked with their personal team or residents and they have a game plan, they might come in and say, this is what we're thinking is going on, this is what we want to do, maybe instead of even like reassessing more symptoms. And I think some of that, going back to the language barrier, even it's helpful when the nurse is doing the intake, right? If they're asking about their height, weight, things like that, or their background, the social history, you can kind of see how we assess their mental orientation as well, how alert they are. So we really can get a lot from that initial encounter as nurses. And so that is something where if we're intentional, it can be really fruitful in getting the information that we need really quickly. And so another part of the role as a nurse is just being that advocate. And so just really tuning into those details. And so that's something I thought about too, with the appropriate steps of care. How would you guys, if your patient is experiencing anxiety and you're a new nurse, do you have personal things that you would do? Maybe like, would you try the pull a chair method, or do you think that's something I'm really open to now? Life-changing.
Yeah, I would try the pull the chair over method. I've also noticed that some nurses who do like intake in the ER, like if they're rooming a certain patient, the patient's a suicidal patient, I've noticed some nurses who actually pull the chair over and then the computer over and like lower it, and they'll actually sit side by side. So the patient's in the bed and then they're doing the suicide intake or whatever mental health intake for the ER as like the initial assessment. And it seems to make a difference with that too. So I definitely try that to kind of get more on a personal level.
And I think it's good, like you said, when they're pulling over that chair next to them and talking to them, not having that computer is like the barrier where they're like, do you drink on the weekend? And they're like typing, and then you're like, you already paying? And then they like pop back over. So it's like a bobblehead kind of action. And so that can kind of feel like you're like, no, I don't. Yes, I do. Like you're like following them. So I think that it would be nice to pull up the chair again and talk to them and kind of relate that way. In my public health clinical, I work with a nurse who she is really about that, like that personal connection, because in COVID, they cannot meet in person for this wellness program where they're writing SMART goals, doing a 6-week course of wellness. And so now she's like, almost like, I have one shot to make them love me, And so she's like, has her paper and pen out. She's like, I'm not using the computer. I'll do double the work and type it in after. So she's like really committed. But honestly, I was really impressed with that because she is so busy, but she's willing to go that extra mile just so you can be like, I stared you in the eyeballs and now I know your name and I know you have a daughter, you know, because she's like willing to do that instead of like the bobblehead method of the computer and typing. And so that was something I was actually kind of surprised about because when you're busy, sometimes as a nurse, you're like, I just have to get this done. I wish I can connect with you, but also can't get a coffee with you because HIPAA. So you're like, sorry. So I think that that was something I was really impressed with. And just finding those ways of really sacrificing something for me personally is like at that clinical, as I'm talking about how to connect, we do pool therapy. And for that, there's like, it's freezing water, freezing. And I was in the pool with these like elderly people, but I actually learned the most about them as I was like freezing in this Titanic water. And I was like, wow, like sacrifice, but I'm learning so much about the patient. So tying that back to like pull a chair method, if it's like, okay, I have to spend 2 more minutes in this room, maybe then I want to, but you can learn so much more about the patient if you're willing to just sit down, figurative cold water or actual cold water as I would do weekly. But yeah, that's something else I thought about too. All right, so I want to talk a little bit about reflection and takeaways. And one of the biggest takeaways I took away was communication, 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 and just really being able to build that rapport. So if I was the nurse in this situation, I would make sure I had a medical interpreter requested if I really did notice that language barrier. And then in that case, we have someone that can ask about their questions, their concerns, and they also know that, you know, everyone's on their side. So having the medical interpreter iterate that as well. I would also make sure I do a thorough assessment during their health history and make sure I'm really assessing those individualized needs of the patient. And then patient education, which is like one of the bedrocks of what we are going to be doing as nurses. And so that would be like talking about the diagnostic testing, about medications, the side effects, maybe the rash that she got. Maybe it might have been nice to know that could happen rather than experiencing it, you know, I mean, like it's here. So maybe just telling her like this could happen, or call your doctor if this also occurs. And then talking about lifestyle impact, talking about those preventative strategies that she can do as a patient to make sure she's maintaining her wellness, coming up for that follow-up testing, and even reassuring her that she's going to have free access to medical interpreters during those appointments of follow-up. So she's building that rapport, building that trust in Western medicine, as we're also acknowledging how important her personalized culture is, her individual culture. So I think those are some of the main takeaways. And honestly, in some of your responses, advocacy was a lot of the foundation of what you guys were saying as well, making sure you're standing up for the patient and their needs. All right, well, these are just references, and I appreciate y'all for sharing your thoughts and talking. That's it.
Good job.
Thank you. Okay.
Yeah, nicely done.
That was really good.
Stop. Is it stop? Stop recording.